the diabetes. So by this time, you all know that diabetes is a very common disease in the society. As I told you that nearly 25 crores are dysglycemic in India. That means dysglycemia means both diabetics and pre-diabetics. Okay. And the most common symptom of the diabetes is no symptom at all. That is asymptomatic in nearly 80 to 85% of the diabetics. But why should you treat an asymptomatic individual with diabetes? Because to protect him from the complications, obviously. So left untreated, they will go have the lot of the complications. Welcome, medical student. Right. You have the different complications of diabetes. So one is microvascular, that involves the very, very small vessels located in the retina, located in the kidneys, located in the nerves. So you have the retinopathy, neuropathy, and the nephropathy as the three complications of microvascular. And you also have the macrovascular complication that involves the large vessels. So that means vessels supplying to your heart, that is coronary artery disease, vessels supplying to your brain, that is a cerebrovascular disease, and the vessels supplying to your peripheries, that is a peripheral vascular disease. In India, along with these micro and the macrovascular complications, you also have the specific complications pertaining to the diabetes in Indian population. They are infections. Okay, you name any infections, that will be more and more in diabetic individuals because they are having hyperglycemia and their immunity levels are at a lower level, and diabetes is also considered as a secondary immune deficiency syndrome. So once the immunity is lowered, so all the bacteria, virus, fungi, etc., so they multiply in the body of the diabetic individuals to give a lot of the specific infections. So some infections are very common in the diabetics. In some infections, you can diagnose the diabetes without knowing that he is a diabetic. For example, foreigner's gangrene. So immediately you can suspect the person could be a diabetic. In the same way, rhinocerebral mucormycosis, what happened in the COVID era. So he must be a diabetic because it's a specific infection pertaining to the diabetic individuals. In the same way, atypical mycobacteria, multi-drug resistant tuberculosis, carbuncles, a big carbuncles on the back of the neck or the nape of the neck and the posterior chest or the paraspinal areas. They are so common in the diabetic individuals. So these infections are very common in the diabetic individuals. So when you are dealing a case of the diabetes, which is an asymptomatic, but still we give the treatment a lifelong just to protect him from the complications which are life-threatening, leads with a lot of the mortality and also the morbidity. So in this class, I tell you something about the microvascular complications. So what is the basic pathology here? It is a progressive narrowing and occlusion of the vascular lumen. So the progressive narrowing of the lumen. So once there is a progressive narrowing, obviously the blood supply to the distal areas will be blocked or will be compromised. So because of the narrowing of these vessels, because of the compromised blood supply to the distal parts, you will have a impaired perfusion, and that leads to the ischemia. And obviously due to chronic ischemia, so definitely the tissues will damage. So the specific part cells are involved in these complications. If you see the retina, endothelial cells, pericytes, Muller cells, and the ganglion cells. So these cells are involved in the retina. Renal glomeruli, you have the mesangial cells and the podocytes. And in the peripheral nerves, you have the Schwann cells, endothelial cells, and the pericytes. So these cells are very, very important for the pathology point of view. See, sometimes when you are in a doubt, the patient is having the massive proteinuria, is a diabetic. You are in a doubt whether this proteinuria is because of the diabetic nephropathy or something else, or a non-diabetic kidney disease. So in such situations, we advise the biopsy, renal biopsy, and then in the renal biopsy, what the cells we are going to see that the glomeruli, the mesangial cells, the podocytes, these cells will have a peculiar characteristics in a diabetic nephropathy, and then the renal pathologist will diagnose you as this disease is because of the diabetes. So this is a diabetic glomerular disease, etc. So in that way, you can diagnose these conditions. In the same way, the peripheral neuropathy, neuropathy, you will have the Schwann cells, abnormality, endothelial cells, and the pericytes. See, all the complications are because of the chronic hyperglycemia, not an acute hyperglycemia. Just you can see in the ICU cases. See, some of the cases admitted in the hospitals, and before there was no history of the diabetes. But at the time of the admission, the blood sugar is 210 or 220 or 230. And after a few days, again the blood sugars will come down. So this is called acute hyperglycemia because of the stress, because of your excessive counter-regulatory hormones like your adrenaline, norepinephrine, etc., etc. But diabetes means a chronic hyperglycemia. So the hyperglycemia should stay for a longer period to consider as a chronic hyperglycemia. See, what are all the pathways it disturbs chronic hyperglycemia? In other words, diabetes, a polyl pathway is advanced glycation end products pathway, PKC pathway, hexosamine pathway. So these pathways will be disturbed, so that this leads to a lot of the changes. See, for example, polyl pathway. So there will be the reduced levels of the reduced glutathione. So that is very, very important for the metabolism of these amino acids and etc. ACE pathway activated, activation of the ACE receptors, so that the receptors will die much prematurely. There will be the modification of the intracellular proteins. So the proteins modification definitely will give less energy to the cells, and cell death will be there. Increase the levels of the pro-inflammatory cytokines. So the more the pro-inflammatory cytokines like procalcitonin, these people will go into the septicemia much early. So in the same way, PKC pathway reduce nitric oxide. Nitric oxide is a good vasodilator. So once there is a nitric oxide reduction, there will be the vasoconstriction. Once there is a vasoconstriction, there will be massive myocardial infarction or CVA or the peripheral vascular disease. And increased growth factors, VEGF means growth factors, increase the levels of the pro-inflammatory cytokines. So these are all PKC pathway. Hexosamine pathway reduction. So there will be increased N-acetyl glucosamine, altered gene expression, increase the levels of the pro-inflammatory cytokines. So basically, to get all these complications of the diabetes, internally at the cellular level, these changes will occur. So these are all because of chronic hyperglycemia. So our motto is, whether the fellow is a diabetic, a chronic diabetic, or extensive diabetic, if you keep the chronic hyperglycemia as euglycemia, what you mean by euglycemia? Fasting blood sugar around 100, postprandial blood sugar around 150, you can almost block all these pathways. Once you block all these pathways, what will happen to the organs? Organs will be free. You won't get any complications. You won't get any myocardial infarction or nephropathy or neuropathy, etc., etc. All these complications are because of these pathways. All these pathways because of the chronic hyperglycemia. So in diabetes, our motto is, don't keep in chronic hyperglycemia, keep it in euglycemia. Keep it in euglycemia. See, now move on to the diabetic kidney disease. Okay, so this is called as DKD. You know CKD. Okay, what is CKD? Chronic kidney disease. What is DKD? Chronic kidney disease because of the diabetes. Okay, so then you can specifically say that it is a DKD. DKD means a chronic kidney disease due to diabetes. Who consider as a DKD or the CKD because of the diabetes? See the definition of the diabetic kidney disease. Based on the presence of albuminuria and the reduced eGFR. So this you should understand. So all these years, what we know, CKD means elevated creatinine. Creatinine 4, 5, 6, 7, etc. It is CKD. So the patient is a diabetic, it is a DKD. Now, today, you should also know that not only your elevated creatinine, albuminuria is also important. Albuminuria is also a part and parcel of DKD. So when the urine shows protein 2 plus, sugar 3 plus, creatinine 0.9, are you giving importance to that patient or not? You should or should not? You should give importance to that patient, even though the creatinine levels is normal, because he is passing proteinuria. He is having proteinuria. So from tomorrow onwards, you please give importance to the proteinuria also, along with your creatinine. You have the two cases. One case, creatinine 3, proteinuria 2 plus. Okay. Another patient, creatinine normal, proteinuria 2 plus. Both are DKDs. Both are DKDs. Both are diabetic kidney diseases. Even though there is elevated creatinine or not, but once you have the proteinuria, you should be considered as a diabetic kidney disease. Why I am stressing this point? Most of our clinicians, they don't give much importance to the protein, urine protein. They just give importance to only creatinine. So if you don't intervene at that juncture by introducing your ACE inhibitors or ARBs or reduction of your fruit juices or reduction of your salt or control of your blood pressure, the next year or in the next 2 years, these people's creatinine will go up. Once if you give concentration on this proteinuria, once you start a treatment for this proteinuria, the creatinine rise will be there after 5 years or after the 10 years. So you'll have a good quality of the life by postponing the elevation of the creatinine in that particular person. Otherwise, in the next 5 years, he may require dialysis or a transplantation. Am I clear? So from tomorrow onwards, please give importance to the proteinuria also along with your creatinine levels. So that is DKD. DKD means either proteinuria or elevated protein, elevated creatinine. Elevated creatinine is nothing but reduced GFR. Okay. How you get the GFR? So in your smartphones, you add the patient's age and gender, either the male or the female, and enter the creatinine levels. If you give all these three, immediately you will get the GFR. With your age of the patient, sex of the patient, and creatinine levels, you will get the GFR. And according to the GFR, you can divide the CKD into 5 groups. That you know that. Okay. So GFR more than 90, stage 1. 60 to 90, stage 2. 30 to 60, stage 3. Again is divided into A and the B. So 30 to 45, 45 to 60. And stage 4 is GFR between 15 to 30. And stage 5 less than 15. Also considered as ESKD, end-stage kidney disease, where only 2 options, either dialysis or transplantation. Again, the transplantation either live related or distant related or unrelated. And then the dialysis, you have the 2 types, hemodialysis, peritoneal dialysis. So that's how the GFR will help you, not the creatinine levels. Okay, so CKD is divided into 5 groups according to the GFR only, not according to your creatinine levels. Because the creatinine levels of 1.5 for this fellow, GFR is different from the second one, the creatinine of the 1.5. The creatinine is same, 1.5 both the individuals. But her GFR is 40, but his GFR is 90. Am I clear? So GFR depend not only on the creatinine levels, but also on the age of the patient and also the gender of the patient. So with that, you can the GFR, and according to the GFR, you can divide the people into these groups. See, in the absence of the signs or the symptoms or other primary cause of the kidney disease, most of the times they don't have any symptoms. Unfortunately, again in India, a lot of the diseases are asymptomatic. Let's see, diabetes is asymptomatic, hypertension is asymptomatic, silent killer. In the same way, CKD is also very asymptomatic in Indian population. Even though their creatinine level is 4, 5, 6, they don't have any loss of appetite or asthenia or inuria or oliguria, nothing. Once you check the creatinine levels, it is 4 and 5. And if you see the patient, ask any symptoms relating to the kidney, no. So that is asymptomatic nature. So all these people, they require either dialysis or transplantation very fast. Once they are in the stage 4 and the 5 and reaching to the end stage kidney disease very fast. Once you diagnose the CKD in the stage 1 and the stage 2, we can postpone that stage 4 or the 5 for a minimum a decade or the 2 decades. That gives a good quality of the life to the population. So don't underestimate CKD or the DKD in all the diabetic individuals. That is the reason on the day of the diagnosis itself, you should check the urine protein levels and also check the creatinine levels, whether the fellow is having the DKD or not, CKD or not. Okay. So because in India, 40 to 50% of the type 2 diabetes, they present with the complications at the time of the diagnosis itself. Okay, na? Suppose Mr. Rao, his blood sugar is 200, fasting blood sugar is 200, postpone blood sugar is 300. First time to your visit. So what is the diagnosis? What is the diagnosis? Good, obviously type 2 diabetes. Okay, because he is 30 years, father is also had a family history, he is having abdominal adiposity, he is having acanthosis nigricans, typical type 2 diabetes. But don't be happy by diagnosing the diabetes, whatever the complications it give, because 50% of the people will have the complication at the time of the diagnosis itself. What complications? Ask about the neuropathy, any tingling or numbness sensation or paresthesias, etc., etc. Ask about the retina symptoms, any dimness of the vision or watering of the eyes, or etc. Ask about the kidney diseases. Okay, any past history of the kidney problem, any past history of the renal calculi, or any past history of the polyuria, any past history of the nocturia, any past history of the dysuria, etc. In the same way, see IHD, any past history of chest pain or past history of the breathlessness, because angina equivalents are very common in the diabetic individuals rather than the chest pain. So once the dyspnea in a diabetic individuals, in the absence of the chest pain also, you should think of the IHD only. Or maybe a atypical angina, maybe the pain in the epigastric region, pain in the jaws, pain in the interscapular region, pain in the left upper limb. So these are all could be a angina equivalents. In the same way, something about your cerebral circulation, maybe TIAs, transient ischemic attacks, or any past history of the hemiplegia, etc. So these are all very, very important in all the diabetic individuals. On the day one, even though you diagnose the type 2 diabetes, don't be happy at that juncture. So please ask for the complications history. And even if the patient says all no, get urine protein level. Urine protein will be 2+. Get the creatinine level. Creatinine level is 1.5. Get an X-ray. X-ray is the normal, obviously, but there may be a mild cardiomegaly. And get ECG. ECG shows LVH. Okay. So send the fellow for the retina examination. Maybe non-proliferative diabetic retinopathy. So these are so common. And you check with the 10 grams monofilament. So there may be a loss of the sensations on the feet, maybe on the dorsum of the feet or on the sole of the feet, etc. So that means this fellow is asymptomatic type 2 diabetes, first time diagnosed. Also diagnosed as a neuropathy, retinopathy, nephropathy. So that is also so common. Okay. So these are all asymptomatic diseases. So the beauty of the knowing the complications on the day one of the diagnosis is very happy incident for you and also to the patient, because you are protecting the patient from the long-term complications. See, all the microvascular complications are the risk factors for the macrovascular disease also. Suppose if the patient is having proteinuria, what is your diagnosis? Nephropathy. This proteinuria is no more a risk factor for the kidney disease, but also a risk factor for the vascular disease, for ischemic heart disease. If you see the two individuals, Mr. Rama and Lakshmi. So Rama is having the proteinuria, Lakshmi is not having the proteinuria. If you follow for 5 years or 10 years, this Rama will die of the myocardial infarction and Lakshmi will stay there. So what is the risk factor for the Rama there? It is because of the proteinuria. So proteinuria is also a risk factor for your heart. In the same way, uric acid levels. All these years, uric acid means gouty arthritis. But now, more uric acid means more vascular events. So reduce the alcohol content, reduce the non-vegetarian content, reduce the purine metabolism, and give the uricogenic drugs, etc. and etc. So otherwise, hyperuricemia may act as an emerging risk factor for the vascular disease. Okay. So what I mean to say that diabetic kidney disease is either proteinuria or reduced GFR because of your elevated creatinine levels, or the both. Most of the times they are asymptomatic. So it is your duty as a diabetologist. They are approaching you. So it is your duty to pick up the early complications. Don't be happy with the diagnosis of the diabetes alone. Pick up for the early complications. That is the beauty of your diabetology course. Most patients will have the long-standing duration of the diabetes and concomitant retinopathy. So this is again a big important point. Kidneys and the retina are very close friends. Once the fellow is having the retinopathy, you should check for the nephropathy, vice versa. Once the fellow is having the proteinuria or the elevated creatinine levels, again check for the retina. So the basic, every year, at least once in a year or once in 6 months, one should be screened for the retina. And also you tell to the patients that whenever he reaches to the ophthalmologist, please ask him to see the retina in a dilated eye. Imagine the importance of the retina in these people, because we are getting the diabetes at an younger age group. All the complications are increasing because we are getting the diabetes at a younger age group. They are living with the diabetes for a longer period. So once he gets the diabetes at 30 years, what is the now normal lifespan? 80+. So he has to live for 50 years with the diabetes. So after 15 years or the 20 years of the diabetic life, so actually you can expect the complication. So once he is about 45 years or the 50 years, he is with retinopathy, nephropathy, neuropathy, and also 1 or 2 IHD blocks, etc. It's very common in the society. So the nephropathy and the retinopathy are very close friends. That you should remember. Why the fasting blood sugar 126? Diabetic, to consider diabetic, there are 4 criteria. What are the 4 criteria? One is fasting more than 126, postprandial more than 200, random more than 200, HbA1c more than 6.5, any one of them. Okay, my question is, why 126 for fasting? Why not 125? Why not 130? So your retina change starts from 126. So you give the importance to the retina in a diabetic individuals. So very important retinopathy. Okay, so you can save the life. Without vision, there is no life. Without movement, there is no life. Okay, so the movement is very important. Sight is very important. So what is the magnitude of the problem? Occurs in 20 to 40% of the patients. The diabetes is very high. 20 to 40% of the diabetic individuals are having nephropathy or diabetic kidney disease. Very high in number. Usual occurs in the type 1 diabetes after 10 years of the disease onset, but may be present at the time of the diagnosis in type 2 diabetes. May be present at the time of diagnosis itself in type 2 diabetes. Okay. So what is the most common cause of death in type 2 diabetes, madam? Red chunni. What is the most common cause of death in type 2 diabetes? Good. Myocardial infarction and ischemic heart disease. So type 2 diabetes people, they die of the myocardial infarction or vascular event. What is the most common cause of death in type 1 diabetes? Type 1. CKD. CKD is very common in type 1 diabetes. Now type 1 diabetes kuda IHD vachestundi because of the obesity. So beginning they are non-obese, but after initiating of insulin therapy and pampering, because the diabetes occurs in most of the people in the children. So the parents pampering and your insulin, good anabolic hormone, they are gaining the weight. And slowly they are also becoming atherosclerotic. And now the ischemic heart is also very common in type 2 diabetes, type 1 diabetes also. But type 1 diabetes more common cause of the death is diabetic kidney disease. Leading cause of the end-stage renal disease across the world, obviously in India also, because we are having #1 country in the world with highest number of the diabetics. Patients with DKD are also at higher risk of dying due to cardiovascular disease. This is a very important point. All the DKD patients, they don't die in the hands of the urologist or the nephrologist. They die in the hands of cardiologists because premature atherosclerosis. So they get arrhythmias. They get massive myocardial infarctions while during the dialysis or at the house. So most of the cause of the death in CKD population is again a vascular death. So that is the reason all the DKD population, you should give vascular protective drugs. What is the most important vascular protective drug? Starts with letter S. Statins. Give the rosuvastatin 10 mg or 20 mg or atorvastatin 20 mg or the 40 mg in all CKD population. High economic burden on the society. So now thanks to the RxD people. Otherwise, all hemodialysis people, every visit, they have to spend at least 2,000 to 3,000 for the hemodialysis. Before the hemodialysis, get the urea creatinine electrolytes. After the hemodialysis, again get the urea creatinine electrolytes. Okay. During the hemodialysis, the blood group, the hemoglobin is 8 or 6 or 7. Get one transfusion and give one erythropoietin injection or one iron dextrose or iron ferric carboxy maltase, FCM, etc. So imagine the cost of the therapy in a CKD population. Very, very costly disease. In the CKD population, very costly disease. See, they need at least 2 to 3 shots, 3 dialysis a week. And every week they have to spend nearly 5 to 10,000 rupees. Okay. What are the risk factors? So these are all the risk factors. Hypertension. See, again, hypertension, the CKD is a very big problem. Resistant hypertension. Triple drugs. Still the BP is not under control. That is resistant hypertension. Very common in CKD population. Lipin retard, a Nicardia retard, etc. You have to give TID. Okay. So, and also you have to give the Minipress XL. Prazosin XL. Prazosin. Okay, 2.5 mg or 5 mg. 1 BD or TID. Again, you have to give the Arcamin, central acting drug. Okay. And again, you have to give the loop diuretics, your Lasix or the torsemide, not 40 mg, maybe 80 mg, 120 mg or 160 mg. In US, you will have the 400 mg Lasix tablet. In India, we are not having. In the Western 400 mg Lasix tablet. And 10 Lasix tablet is a tablet. So you can imagine how much dose of the diuretic you have to give it in the CKD population. Okay, you should not give the ACE or ARB in the creatinine once it is more than 4 or 5 for the fear of hyperkalemia. And you should not give the spironolactone here as a diuretic of choice because it is a potassium sparing diuretic and potassium will go up and again the patient will have hyperkalemia and arrhythmias. So the drugs of the choice in hypertension here are calcium channel blockers, alpha blockers, central acting drugs, diuretics. And you can use the beta blocker. And whenever you use the beta blocker, see the pulse rate. Once the pulse is less than the 50, stop using it. If it is more than the 50, you can use it. Okay, up to 50, you can use the beta blockers. Hyperglycemia. So obviously, we are all the diabetologists. So you can control the hyperglycemia very well. With what? In CKD. With what? Insulin or with OH also. What OHs will be contraindicated in CKD? Begonides? Big no. Again, a word about the begonide. Begonide is simple metformin. Say metformin. So metformin, you respect the GFR. Once the GFR is less than 30, stop it or don't use it. When the GFR is more than the 60, you can use it. When the GFR is between 30 and the 60, you can use the half of the dose. So the metformin, you should remember 30 and 60. Less than 30, don't use it. More than 60, you can use it. Between 30 and 60, use in a reduced dosages. Okay, that is metformin. Then the second one is sulfonylureas. Okay, how many sulfonylureas are there? Glibenclamide, glipizide, glycoside, and glimepiride. Okay, glibenclamide, can you use it in renal failure? Glibenclamide means dionyl. No, long-acting sulfonylurea and produces prolonged hypoglycemia. So don't use glibenclamide. Glipizide, shortest acting sulfonylurea, drug of choice in CKD. Uddanam nephropathy, drug of choice is glipizide, your glinase. Okay, that can be used because shortest acting sulfonylurea. And then glycoside, no. And glimepiride, no. Okay, you may use it at lower dosages, but the best sulfonylurea in the CKD population is glipizide, shortest acting sulfonylurea. And then the third group is alpha glucosidase inhibitors, your acarbose, oglibose, etc. So they will have lot of gastrointestinal side effects. Already CKD fellow will have nausea, vomiting, abdominal distension, discomfort, etc. So you can increase the side effects of these patients. So don't use oglibose or acarbose, even though they are not contraindicated in CKD. They are not contraindicated because they act totally on the intestines only to prevent the absorption of the carbohydrates. You can safely use in the CKD provided if the patient is not having any gastrointestinal symptoms. And then the DP4 inhibitors we have. You have the sitagliptin, saxagliptin, linagliptin, teneligliptin, and then vildagliptin. Okay. So which gliptin is safe in CKD? All the gliptins are the safe in CKD. But linagliptin, you need not change the dose. So you can use the same linagliptin dose irrespective of your renal failure. Am I clear? You are in a doubt. You are not sure of his creatinine levels. You want to use the gliptin. So what is the best gliptin? Linagliptin, because you can use it in whatever may be the level of your creatinine levels. But if you want to use a sitagliptin, so again respect the GFR. So if the GFR, according to the GFR, you can reduce the dose of the sitagliptin. So that is the reason sitagliptin is available. Januvia or your Istavel is available in 100 mg for all routine population, 50 mg for a renal failure population, even 25 mg also is available when the GFR is less than 30 or the 20. Okay, and then finally you have SGLT2 inhibitors. You have dapagliflozin and empagliflozin. So they are very good in CKD population, but when the GFR is less than the 20 or the 30, better not to use the SGLT2 inhibitors like your dapagliflozin and empagliflozin. When the creatinine level is 4 or 5, so better not to continue. Okay. So duration of the diabetes is very important. So longer the duration, obviously more the chance of having the CKD or the DKD. Family history. So these are all runs in the families. Ethnicity. So our Indians and Asians are at high risk. Cigarette smoking is dangerous to the kidneys. Hyperlipidemia. So dangerous, the drug of choice here is the statins. Analgesic abuse, that is the very, very important. Unfortunately, in India, a lot of the people, they abuse it to the nasiyas. So these are all the risk factors for the kidney disease. Structural changes in the kidney disease. So this is mostly our things. See, the pathology involves multiple kidney compartments, not the glomerulus alone. So what are the compartments in the kidney? Glomerulus, young doctor. So glomerulus, you have to see the glomerulus, you have to see the tubules, you have to see the macula. So these are all involved in the diabetic kidney disease. So earliest constant change is the thickening of the glomerular basement membrane. So there will be the basement membrane thickening 1.5 to 2 years after onset of the type 1 diabetes, accompanied by the capillary and the tubular basement membrane thickening. This is followed by the loss of the endothelial fenestration, mesangial matrix expansion, and loss of the podocytes with effacement of the foot processes. Next step is the segmental mesangiolysis with the development of the KW lesions, Kimmelstein-Wilson lesions. That is the nodular glomerular sclerosis. They are most specific for the diabetic glomerulopathy, but are uncommon. Okay, this is most of the pathology. So the two things are very clear from this slide. One is not only it involves the glomerulus, it involves other parts of the kidney also, like tubules, mesangium, etc. And the last one is the KW lesions. They are most specific. Once you see the KW lesion in the kidney, so definitely it's a diabetic one. But they are not that common. They are not that common. So what is the earliest finding is your basement membrane thickening. Okay, I stop here. Any pathologists here? No. Structural changes in the diabetic kidney disease. There is a subendothelial deposition of the plasma proteins, which can compromise the lumen of the small arterial branches, arterioles, and the glomerular capillaries. Subepithelial deposits appear as the capsular drops. Later stages involve the coalescence of the interstitial and the glomerular changes, leading to the segmental and the global sclerosis. Structural changes in the type 2 diabetes are similar to those in the type 1 diabetes, but are more heterogeneous and correlate less well with the clinical presentations. So you'll have the classical pictures in the type 1 diabetic kidney disease rather than the type 2 diabetic disease. So these are all the changes here. You can see the diabetic glomerulopathy here. That is the normal glomerulus, the difference. So the right one is the normal, the left one is the abnormal one. Then you will have the tubulopathy also. So these are the clinical stages. I told you the stage 1, stage 2, stage 3. So according to the GFR. See in the stage 1, there is hyperfiltration and hypertrophy. Okay. In the stage 2, there is normoalbuminuria. In the stage 3, microalbuminuria. And stage 4, overt proteinuria. And stage 5, end-stage renal disease. Abnormal albumin excretion. So this is the hallmark of the diabetic glomerulopathy. See, test for albuminuria annually in all patients with type 2 diabetes, starting at the diagnosis. So in the capital letters, starting at the diagnosis itself, we should check the urine for albuminuria. Test for albuminuria in all patients with type 1 diabetes annually, starting at 5 years after the diagnosis. So in all the type 1 diabetes, all the complications comes later. So on the day 1, there is only hyperglycemia. Whereas the type 2 diabetes, you don't know when the type 2 diabetes started in that particular person. So this is your albumin. You remember the 30, less than the 30 is the normal, 30 to 300 is the microalbuminuria, and more than 300 is macroalbuminuria. So what is your provisional diagnosis here? See the working diagnosis. See, 50 years, very typical Indian patient. He is having the diabetes for the last 15 years. So he got the diabetes at the age of 35 years. He is on OHA, a combination of sulfonylurea plus metformin. Very common combination in Indian population, like your glucored 4 or your Emeril M2, etc. And he presented with the polyuria. So BP is 160 by 100, weight 70 kgs, height 164. Okay. What is the BMI? Is it ideal body weight? So height minus 100, 164 minus 100, 64. So plus or minus 2 or 3, 70. His BMI may be 24 or 25. Fasting blood glucose 210, HbA1c 11.7, albuminuria present, retina examination present. See, unless you here You concentrate on the albuminuria and the retina, you are missing nephropathy and retinopathy. That's what we commonly do in our routine practice. Okay, so you'll be happy with the fasting blood sugar, your HbA1c and the blood pressure. So in uncontrolled diabetes with HbA1c is 11.7 and also having hypertension. Okay, now the nephropathy and also retinopathy. So this is a very high risk individual. What is the age? 50 years. So imagine his quality of the life. So he has to live for another 30 to 35 years. He has to live another 30 to 35 years without any myocardial infarction or without CVA or without any amputation or without any laser therapy or proliferative diabetic retinopathy, etc. or without any transplantation. So this is our motto in this case. So what is your provisional diagnosis? Type 2 diabetes, uncontrolled, hypertension, and microvascular complications, 2 microvascular complications, retinopathy and nephropathy. So what further investigations to be done? All the microvascular complications, check for the other microvascular complications, also the macrovascular complications. So check for nephropathy is there, neuropathy is there or not, with the 10 grams monofilament or with your biphasyometer or vibration sensations, etc. And also get an ECG done, send it for 2D echo and also the TMT to rule out asymptomatic cardiac disease in this patient. How will you manage this patient? So first management, diabetes control. So that is the root cause for all the complications of the diabetes. So control the diabetes here, hyperglycemia. How to control? So his fasting blood sugar is 210, A1C is 11.7. So how to control? So start with insulin. Which insulin? To control the fasting hyperglycemia? Basal insulin. Name the basal insulins: glargine, detamir, or the degludec, or your lantus, or your tresiba. Okay, lantus, that is your glargine. What is the dose? Starting dose? 10 units. 10 units or 0.1 unit per kg body weight. Okay, suppose he is 80 kgs, 8 units. In that way. So you forget those weight, etc. Just remember 10 units. So give 10 units at the bedtime. Okay, and then after 3 days, again check the fasting blood sugar. Suppose in the next 3 days, the fasting blood sugar is 160. What to do? Today we started with 10 units. After 3 days, the fasting blood sugar is 160. What to do? Increase the dose or continue the same dose or reduce the dose? Increase the dose. By how many units? 2 units. 2 units. Okay. So 12 units to are giving on the 4th day. And after 3 days, the fasting blood sugar is 100. So what to do? Continue or reduce or increase? Continue the same dose. After 3 days, the blood sugar is 60. Fasting blood sugar is 60. So what to do? Reduce. Reduce by 2 units. Okay. Again after 3 days, the fasting blood sugar is 160. What to do? Increase. After 3 days, the fasting blood sugar is 100. Continue. No dose change. And after 3 days, the fasting blood sugar is 160. Increase. After 3 days, the blood sugar is 60. Reduce. Very simple. You don't require any MBBS degree also to start the basal insulin. So how much basal insulin you have to start? 10 units. Remember 10 units. Give 10 units. Check the fasting blood sugar. And adjust the dose according to your fasting blood sugar. So that's how you have to control the fasting hyperglycemia. Fasting hyperglycemia. What about your albuminuria? 1 gram per day. What about this blood pressure? So in blood pressure, you have the 4 drugs: A, B, C, D. A means ACE inhibitors or ARBs. B means beta blockers. C means calcium channel blockers. D means diuretics. E means other drugs, central acting or vasodilators, etc. So which drugs you use? A, B, C, D. Out of A, B, C, D, ACE or ARB are the compelling indications to use in diabetes. All the diabetics, if you want to use the antihypertensive medication, A is very important. Okay, okay. Suppose the blood pressure is 160 by 100. Okay, so do you require only single drug or combination? Combination. So now the combination means A plus either C or D. D means diuretic. So D here is hydrochlorothiazide or chlorthalidone, thiazide diuretic, not loop diuretic, not spironolactone. Okay, A plus D. D means either hydrochlorothiazide or chlorthalidone. Otherwise, A plus C. C means either your amlodipine or cilindipine, or amlodipine or cilindipine. So that's how you have to treat the blood pressure part. And albuminuria, there is no specific drug for the albuminuria. Anyhow, you are using your telmisartan or ARB for the blood pressure. The same drug will also act for your albuminuria part. Okay. Any drug for your retinopathy, non-proliferative diabetic retinopathy? No drug, but control blood sugars very effectively, control blood pressure effectively, control cholesterol effectively, stop smoking, and then review after 3 months or 6 months. Already he is having the problem. So not 1 year, once in a year, maybe after 3 months or the 6 months, again check the retina for any progression of the disease or any regression of the disease. Am I clear? So these are very common cases we see often in our practice. At the age of 50 years, with 15 years history of the diabetes, and also uncontrolled diabetes, hypertension, and with nephropathy, and neuropathy, and retinopathy. So this is the heat map. The name given to this map is heat map. On one hand, you have the GFR. On the other hand, you have the albuminuria. See, that is the DKD. DKD means either albuminuria or GFR reduction or the both. See, how many are there in the red? Most of them are in the red only. So that shows even though the patient is having microalbuminuria, even though the patient is having just elevation of the creatinine, that is very dangerous in all the diabetic individuals. The green is only 2. When the GFR is more than the 90 and the albuminuria less than the 30. Okay. Otherwise, once the proteinuria is more than the 30, either yellow starts there, or when the GFR is less than the 45, then this starts. So this is the very, very important. What are the causes of the sudden drop in the GFR? Dehydration. So this is a very important. All the diabetic individuals should avoid dehydration. Obstructive uropathy, that is your caliculi, etc., or maybe your prostatic hypertrophy. So BPH also will cause obstructive uropathy. And use of the drugs like NSAIDs, fibrates, certain antibiotics, indigenous medications. So these are all the reasons for your sudden drop in the GFR. So these 4 you should avoid in all the DKD population. What are they? NSAIDs, aminoglycosides, indigenous medications, Rampachadavaram, Maridimilli. Okay, these are all, they give a lot of the chakka medicine. Chakka mandu antaru. Leda naatu mandulu antaru. So they are all having the chemicals, metals. They damage the kidneys very fast. So don't entertain other than any allopathic medications for any DKD population. So indigenous medicines, they always damage the kidneys. Recent initiation of the SGLT inhibitors or ACE or ARB is usually self-limiting, and there will be the less than the 30% drop from the baseline. This is the very important point you should remember. Once you started the telmisartan or the ramipril, the cartase, etc., there may be the initial elevation of the creatinine levels. So the initial drop, once the initial elevation in the creatinine means drop in the GFR. So there will be the drop in the GFR, but the drop should not be more than 30%. Suppose you started the ramipril your creatinine level, baseline creatinine level is 1. And after starting the creatinine level, ramipril or your telmisartan, that creatinine level is next visit 1.1 or 1.2. Okay. So after starting your AS or ARBs, so there will be a elevation in your creatinine levels that is not more than the 30%. Suppose next week the creatinine level is from this week, this month 1, next month is 2 creatinine level. So that means there is 100% hike in the creatinine levels. So that is something different. So that shows a bilateral renal artery stenosis. Infections, especially those of the urinary tract, are very, very common in our Indian population. Ascending infections, your E. coli, your streptococci, etc. and etc. So definitely they cause ascending infections and pyelonephritis, and very, very common. Sometimes the pyocele, the patient will be present with the septicemia. So definitely sometimes nephrectomy is also advocated for these cases. So this is another case. A 60-year-old lady with 11 years history of the type 2 diabetes and hypertension. So she got both diabetes and hypertension. On therapy with sulfonylurea and metformin combination, a typical Godavari patient has been found to have the albuminuria of 1.5 grams per day. Okay. Retinal examination is the normal. Okay. So what is the working diagnosis here? Diabetic and hypertension. Diabetic and hypertension. And now albuminuria. So is this diabetic nephropathy or not? Questionable. Could be, could not be. Could be because the patient is a diabetic, 11 years, having the proteinuria. So probably of the diabetes region. Could not be because the retina is normal. So once you have the 1.5 grams is a very high number. Okay. So even at the 1.5 grams per day proteinuria, there is no changes in the retina. So that means immediately you should suspect some non-diabetic cause of proteinuria in a diabetic individual. Am I clear? So you should know that there is a diabetic causes of the nephropathy and also non-diabetic causes of the nephropathy in a diabetic individual. When the fellow is having a concomitant retinopathy, it is definitely because of the diabetes. When the patient is not having a concomitant retinopathy, you think twice before labeling as a diabetes as the culprit for this proteinuria. So what is your diagnosis here? Is a non-diabetic, could be a non-diabetic cause of the proteinuria in a diabetic individual. How would you further evaluate this patient? So ultrasound abdomen, okay, etc. and etc. How would you modify the management? So I will come to a later time. So when to suspect a non-diabetic renal disease in a patient with the diabetes? A short duration of the diabetes. Duration of the diabetes is less than 5 years. Absence of the retinopathy. Grossly elevated lipids. Yesterday I have seen one fellow, triglycerides, 1500 triglycerides. Total cholesterol 350. LDL is 240. Non-HDL is almost somewhere between 300. Okay. So very high dyslipidemic fellow. If that fellow is also having the albuminuria, so this is because of the elevated lipids, not because of the diabetes. Active urinary sediment like hematuria, pyuria, CAS. History of the clinical features of the primary renal disease preceding the onset of the diabetes. So if the fellow is having these features, so this could be because of the non-diabetic reason. One, the duration of the diabetes. The second one is absence of the retinopathy. The third one is very high lipids. And the fourth one is active urinary sediment like hematuria, pyuria, CAS, etc. And history of the clinical feature, past history of the kidney problem before the onset of the diabetes. Diabetes history is 2 years or 3 years or 5 years. But the renal problem history is more than that 5 years, maybe 6 years, 7 years, etc. So that could be the reason for this albuminuria. Great. So workup with suspected non-diabetic renal disease, kidney disease without the retinopathy, ultrasound abdomen, anukunnam kada, ultrasound abdomen. If the normal sized kidneys, renal biopsy, advise the renal biopsy. In the ultrasound abdomen, there is a contracted kidney, probably chronic glomerulonephritis or chronic pyelonephritis, and renal biopsy is not indicated. So in all these people, when you suspect the non-diabetic cause and get the ultrasound done, if the ultrasound is the normal in size, go for the renal biopsy. If the ultrasound shows a contracted kidneys, pyelonephritis, etc., then the biopsy is not needed. Treatment of the diabetic kidney disease. So again, the root cause is diabetes. In any disease, any complication, so first treat the diabetes very effectively. That is the one. And then the blood pressure control. All the kidney problems, CKD population will have hypertension. So hypertension could be a cause of the kidney disease, or maybe an effect of the kidney disease. ఏది ముందో చెప్పలేము ఒకసారి. Hypertension will attack the kidneys to cause the CKD, and the CKD will produce the hypertension, and again hypertension will damage the kidneys. So it's a vicious cycle. Hypertension, kidney problem. So lipid control. So give some statins. Diet control is very, very important. So what diet you advise for the CKD population? No salt, no fruits, no coconut water, no non-vegetarian. Very, very difficult. Very, very difficult for a kidney patient. Imagine no pickles Sunday, no salt, no non-vegetarian, no masala. Compliance diet in CKD is very, because the sodium and SGLT inhibitors are very much needed in the early stages of the DKD, not in the late stages of the DKD. So now the SGLT inhibitors are the favorite drugs for the nephrologists and the cardiologists, even in the absence of the diabetes. And RAS blockade is a very, very important. So these six are very important for the diabetic kidney disease. So glycemic control, BP control, lipid control, diet, SGLT inhibitors, provided if the creatinine level is not very high, and RAS blockade, again when the creatinine level is not high. These are the important drugs to be used. So for all the diabetic kidney disease, one statin, one telmisartan, and then one statin, your rosuvastatin. So these three are very must. Now another case. Type 2 diabetes for 18 years. He is 54-year-old. Okay. In the early 30s, he got the diabetes. He has come for his annual checkup. A1 7.2. Blood pressure 142/96. No postural hypotension. His TMT is normal. Foot examination is normal. Retina shows non-proliferative diabetic retinopathy. So NPDR. 24 hours urine examination, 280 milligrams of albuminuria. So that means microalbuminuria. Normal is less than 30. 30 to 300 is microalbuminuria. More than 300 is macroalbuminuria. His creatinine level is 1.3. See, at the 1.3, his GFR is 40. Okay, 140. One GFR is 40. Medications: Dimiparate 4 mg, metformin 1000 mg, amlodipine 5 mg. So what is the working diagnosis? So he is a diabetic, he is an hypertensive, he is having DPR, NPDR, non-proliferative diabetic retinopathy, he is having nephropathy also, albuminuria. Okay. Now, so does he need any addition or modification in his medication? Now again go to the DKD, diabetic kidney disease. What are the medications you should prescribe? Diabetes control, BP control, lipid control, diet control, RAS blockade, SGLT inhibitors. Glycemic control is very important. It has been very important. So these are the different studies. A1C reflects a mean glycemia down to an EFR of 30. Below this threshold, A1C values may be falsely low. SMBG. So BP targets. What are the targets in the BP? Try to reach that level. 130 to 130/80. 140/90 is always dangerous. 140/90 is an hypertensive. So try to reach your figure of 120/80 without causing any hypotension, without causing any dizziness or etc. So ASR, ARBs are very, very important. Why these are important? 4 features. One is anti-hypertensive drugs, vasculoprotective, renoprotective, cardioprotective. So these are very important. Vascular protection, renoprotection, cardioprotection, along with it, BP reduction. So that is the reason these are the drugs of the choice. Mineralocorticoid receptor antagonist finerenone has been shown to reduce the progression of the kidney disease in patients with type 2 diabetes and albuminuria. So now that drug has entered into the market, finerenone, very good drug, but very costly drug. But those people who can afford So definitely that is a good drug. This is the steroid sparing mineralocorticoid receptor antagonist. Your spinolactone is steroid sensitive, but this is a steroid sparing. Phenomenon 10 mg and 20 mg. When the GFR is less than 30, we use 10 mg. When it is more than the 30, we use 20 mg. So these are the contraindications. In pregnancy, don't use diuretics, don't use ACE or ARBs. In pregnancy, what drugs you are prescribed? Your calcium blockers, your beta blockers, or both labetalol, both A and B. Yeah, alpha blockers and beta blockers, combined blockers. But don't give diuretics and ACE or ARBs in pregnancy. Bilateral renal artery stenosis, don't give the ACE or ARBs. Intolerance, particularly dry cough. In some people, know dry cough is very, very high in these individuals. See the phenomenon. It has been shown to reduce the progression of the CKD in patients with the type 2 diabetes and albuminuria. Indicated in patients who are at high risk of CKD progression, that is persistent albuminuria, in spite of the maximum tolerated dose of the ACE or ARBs. Use only in the patients with the persistently normal serum potassium and monitor the potassium levels regularly. Hold if the levels are increases more than the 5.5. Contraindicated if the GFR is less than 25. Dosage is 10 mg and 20 mg when the GFR is more than 60. Can be used in combination with the SGLT inhibitors and ACE and ARB. So this is the recent drug entered into the market in all the CKD population to improve the kidney function. Along with your SGLT inhibitors and ACE or ARBs, you can use this. So while using this, two things are very clear. One is the GFR and the second one is the potassium levels. When the potassium levels are very high, hold it. When the GFR is very low, use 10 mg. When the GFR is good, use 20 mg. See, protein restriction. So it should not be there in Indian diets. So in fact, Indian diet itself is a protein insufficient diet. So Indian diet is low in the protein and is mainly of the vegetarian origin. Hence, protein restriction is often not needed in the Indian patients. Sodium restriction is also recommended. Very important. So what is the amount of the sodium we eat every day? 10 to 12 grams. 10 to 12 grams is the average sodium we eat every day. But what is the requirement? Less than 2.3 grams. So definitely papads, pickles, non-vegetarian diet, so frozen foods, your French fries. So these are all contain a lot of the sodium. Avoid nephrotoxin drugs, smoking, etc. See, early and aggressive treatment of the UTI. Very early and aggressive treatment of the UTI. Otherwise, the ascending infection is very fast, especially in uncontrolled diabetic individuals. They give lead to emphysematous pyelonephritis, necrotizing pyelonephritis. Sodium and phosphate restriction as and when indicated. Lipid lowering therapy, HMG coenzyme A reductase inhibitors, that means statins. Refer to the nephrologist if creatinine rises or hyperkalemia is present or when the GFR is drops below the 30. Another case, a 70-year-old male with 15 years history of the type 2 diabetes and hypertension. So he got this at the age of 55 years. Okay. Now he is 70 years. Diabetes and hypertension. He is getting glycoside and metformin. Now complaints of increasing swelling of the feet. Blood pressure is 160 by 100. High. Urea elevated 60. Creatinine elevated 1.5. Cholesterol normal. Triglycerides near normal. Fasting blood sugar high. PP high. 280 and 380 respectively. And potassium upper normal. 5 milligrams. So what is your working diagnosis here? So one elderly individual, elderly male, okay, with diabetes and hypertension, is on OHA, now complaining the swelling of the feet. So shows uncontrolled hypertension and also renal failure. So creatinine is elevated, urea is elevated, normal normal cholesterols, high blood sugars. Potassium is also high. So what is the working diagnosis here? Diabetes, hypertension, CKD, yeah, and then hyperkalemia, near hyperkalemia. That is also very important. That also you should give a lot of importance in this patient, because by prescribing the drugs, how would you further evaluate this patient? So what are other investigations you require here? You require HbA1c. Okay. You require LDL cholesterol, HDL cholesterol. Okay. You require LFT. Okay. You require thyroid profile. Yes. You require CBP, your hemoglobin. Okay. Total count, etc. You require urine, complete urine examination. Okay. What about the fundus? Yes. What about ultrasound abdomen? Yes. Chest X-ray, ECG. So these are all the investigations you require in this patient at this juncture. So now you modify the management. Yes. Yes. Is it AKA or CKD? AKA means acute kidney injury. CKD means chronic kidney injury. Is it AKA or CKD? CKD, because what is the elevation of the urea? Elevation of the urea is more or creatinine is more in this patient? Not urea. Creatinine is more. Okay. What is your creatinine level? 1 kada normal. 1.5 వచ్చింది creatinine. So in that way, it is a CKD. Another point to the CKD, swelling of the feet. So that will not be there in AKA, but here it is more of the swelling of the feet is there. So that shows CKD. Okay. So this patient is diabetic, hypertensive, CKD, and other investigations are required to add other diseases like any IHD or any retinopathy, etc., etc. A modification of the treatment. What are the metformin? What are the glycoside? Adi kuda stop chesedam, because for the fear of any severe hypoglycemia, etc. So this is the time to start insulin, because the sugars are very high. Fasting blood sugar and PP. So what insulin you use here? Is it a basal insulin? Is it sufficient? No, because it requires both fasting reduction as well as PP reduction. Suppose postprandial is 200, fasting is 280. So you can give basal insulin to control the fasting. But here basal insulin is not sufficient, because fasting is high and also the PP is also high. So you require both basal bolus therapy or the basal insulin plus the regular insulin, etc. What about the BP? 160 by 100. 160 by 100. So you require at least 2 or 3 drugs here. One is diuretic. So which diuretic you use here? Is it chlorothiazide or hydrochlorothiazide or Lasix? Loop diuretics are required because he is having swelling of the feet. So it's a symptomatic edema. So in a symptomatic edema, obvious edema, when the creatinine level is more, 1.5, if you see the GFR somewhere at 40 or 30, so definitely you need furosemide here, the loop diuretics, either furosemide or the torsemide. Okay. And then what about the ART, ARB, angiotensin receptor blockers? Tell me, Sartan. Okay. So any role of here amlodipine here or cilindipine? Any role of the phenernon? You can use the phenernon here. So that's how you have to prescribe it. So how to reduce the potassium levels? Potassium level is 5 here. How to reduce? Once you give the diuretic, so obviously electrolyte loss will be there. Okay, that is one. And then dietary approach. So avoid so these things, potassium foods. So definitely that will help. Suppose here the potassium is 7.5. Or potassium level is 7.5. A diabetic, hypertensive. So you have to use K-bind sachets. Potassium binding sachets are available in the market. So you have to give 1 BD or 1 TAD along with the water. So those sachets will reduce the potassium levels in the blood. So they are called K-bind sachets, potassium binding sachets. When the potassium level is 7.5. Luckily I have taken ECG and ECG shows normal. So what expectation, what changes you expect in hyperkalemia? T waves, very tall T waves, sharp T waves, pointed T waves. Not like a T wave is like this. That is more of ischemia. But in very tall and sharp T waves. Okay. So in that way you can treat these patients. So these are all working diagnoses. So whenever you see these such type of the patients, treat the diabetes. Here fasting is very high, BP is very high, stop OHA, start insulin and act accordingly. And then the hypertension, you need a calcium channel blocker here, you need a loop diuretic here, you need a ARB of the lower dose here. Okay. And then you may add the phenomenon which the patient can afford. And then potassium, at this juncture, not needed, drug therapy is not needed, but your diuretic therapy and your dietary restrictions may reduce the potassium levels to very good. So she needs an ECG also to rule out any hyperkalemia changes. So the glycemic management. Patients with ESR at advanced stages often experience drastic reductions in their requirements of the insulin and other anti-diabetic medications. ఇది ఒక క్లూ అనమాట మనకి ప్రాక్టీస్ లో. సుబ్బారావు ఎప్పుడు వచ్చేవాడు, లాస్ట్ 6 months నుంచి రావడం లేదు రెగ్యులర్ గా ఫాలో అప్ కి. ఇప్పుడు చూస్తే షుగర్స్ అన్ని ఫుల్ కంట్రోల్ ఉన్నాయి. ఎప్పుడు అది కంట్రోల్ ఉండే కాదు అంటే ఇమీడియట్ గా మనకు అర్థమైపోతుంది. ఏం అర్థమైపోయింది? యూరియా క్రియాటిన్ పెరిగిపోయాయి. సో వన్స్ ద renal failure set in, the sugars will come down. And you will get the frequent hypoglycemias also. So any patient, a long-standing diabetic, now the patient is getting the hypoglycemia and the sugars are coming to the normal without any change. Okay, he has not changed. So always suspect diabetic kidney disease. So check the urea and the creatinine levels. So this phenomenon is due to decreased renal and hepatic insulin clearance. Decreased renal clearance and decreased hepatic clearance, a decline in the renal gluconeogenesis, deficient catecholamine release, diminished food intake, protein energy wasting, and the hypoglycemic effects of the dialysis treatment. Patients will require de-intensification of the treatment with the avoidance of the medications likely to cause hypoglycemia. So don't use the hypoglycemic agents in those individuals. When the fellow is on the sulfonylureas, stop it. When the fellow is on the metformin, respect it with your GFR levels. So that finishes our diabetic nephropathy and diabetic kidney disease.